Good evening. I call this hearing to order. First, I'd like to welcome our witnesses this evening, Dr. Stone from the Veterans Health Administration, Dr. Avioli from the National Institutes of Health, Dr. McCune from the Substance Abuse and Mental Health Services Administration. Today's hearing will be the first of many this committee will hold as it begins the critical work to address veteran suicide. I think we can all agree how important it is to take care of our veterans, which is why I have made ending veteran suicide my #1 priority. Sadly, America is facing a national public health crisis that demands urgency from Congress, the administration, medical and clinical professionals, veteran service organizations, and veterans themselves. This morning, we lost another veteran to suicide at a VA hospital. 2 weeks ago, 3 veterans committed suicide on VA property in just 5 days. 7 veterans have ended their lives on VA campuses this year. It's clear we are not doing enough to support veterans in crisis. While these incidents may be alarming, they do not tell the full story of veteran suicide in our country. It is harmful to veterans and overly simplistic solely to blame VA for these tragedies. We must come together as a nation to address this crisis. Too many Americans have been personally touched by this troubling trend. For me, it was my own uncle, a Vietnam veteran who died by suicide. I still remember the day that I came home in September when I was 10 years old to find out that my uncle Sabado, a Vietnam War veteran, had taken his own life, and he lived across the street from my own family. His suicide still haunts me from time to time to this day. Each day, 20 veterans, service members, reservists, and members of the National Guard die by suicide. One veteran lost to suicide is one too many. But 20 deaths a day, totaling more than 7,300 deaths per year, is unacceptable. To put this in perspective, that's 1,800 more deaths per year than the 5,429 service members who have been killed in action since 2001. Both numbers are surprising and further evidence of a frustrating and persistent problem that we failed to adequately address. So, if I may move this poster closer. When you examine the statistics, barriers to access many veterans face become very clear. Only 6.1 of those deaths are veterans accessing services at VA. But 10.6 deaths a day are veterans not using the VA at all. And 3.8 current active duty or members of the National Guard are also committing suicide. We all have a responsibility. We all have the responsibility to act because there's no excuse for failing these veterans here at home. My Republican colleague, Ranking Member Rowe, often says, we haven't moved the needle far enough to reduce veteran suicide, and he's right. That number has held steady at 20 deaths a day since 2014, for far too long. It's time for Congress to look at this crisis with fresh eyes. In 2015, Congress passed the Clay Hunt Suicide Prevention for Americans Act, otherwise known as SAVE Act. But this well-intentioned effort hasn't done enough. Recently, I met with several members of Clay Hunt's unit who identified the specific challenges they faced as they transitioned out of the military. We need to understand why this legislation hasn't done more to prevent suicides. We need to expand our understanding of mental health among veterans. We need to commit to providing the resources needed to implement a comprehensive plan. Most importantly, Americans must hear from and listen to our veterans. We need to hear from veterans who have attempted suicide, understand their circumstances, and find out what they believe worked and what failed. These veterans have a story to share that can tell us something about our attempt to address suicide and how responsive government can be to their situation. This committee will not be indifferent to the problems veterans face, nor will we turn a blind eye to the many causes that lead veterans to committing suicide. And I'm glad that we could all come together today to begin to tackle this important issue. Ultimately, it's up to all of us to reduce and prevent veteran suicide, because this is not a problem that VA can solve alone. We know that dedicated doctors, nurses, and VA employees saved over 240 veterans from committing suicide on VA campuses in recent years. VA briefs me on each suicide at a VA facility, and there's still so much that we don't know. We must involve partners at the federal, state, and local levels and do a better job of supporting veterans in need, regardless of whether that need is clinical or social. By supporting clinically effective programs and increasing access to programs that mitigate the impact of concerns, be they financial, marital, substance abuse related, or physical health, veterans will feel the support they seek. VA must also ensure that every interaction it has, not just in a clinical setting, makes veterans feel supported. One example from VFW struck me when I was reading the statements for the record from the VSOs. And I quote, "The VFW was working with a veteran who was rushed to a VA hospital during a mental health crisis caused by untreated bipolar disorder and depression. The veteran was admitted to the medical center's inpatient mental health care clinic for 2 weeks, despite not being eligible for VA health care. VA did save his life, but now he has a $20,000 bill. His mental health crisis was exacerbated by unemployment and his inability to provide for his family. With proper treatment, he has been able to return to work, but still lacks the resources to pay the VA bill. The VFW is working on having his bill waived, but he will never return to VA if he has another mental health crisis," end quote. Now, this is just one more testament to what we already know. When a veteran is faced with the sky-high cost of medical care, that can be a significant barrier to getting the help they need. To really combat this crisis, we will have to change our mission. We must re-examine our approach to suicide prevention, exhaust our research possibilities, break the stigma faced by those seeking mental health services, and expand the health care and support we offer veterans. Like all of those in this room, I believe Americans are ready to meet this challenge. Countering this crisis will require us to shine a national spotlight on veteran suicide. And there is still so much that we do not know. We need to better understand the root causes driving veteran suicide, hear from the families who have lost loved ones, and listen to the clinicians and social workers who are on the front lines battling to end veteran suicide. As Americans, we are proud of the service and sacrifice that they have made for our country. But a thank you for your service isn't enough for our veterans in crisis. Instead, we must thank and honor our veterans with action, work together to deliver top quality health care, provide community support, and ensure we offer a stable transition out of military service and into quality, sustainable employment. Truly thanking veterans for their service means helping them when they need it most and to rise above political opportunism to support veterans in crisis. It is my hope that together we can curb this crisis. Now, before I recognize Ranking Member Rowe, I'd like to point out that May is Mental Health Awareness Month, and we all have to do our part. I encourage every member of this committee to record a suicide prevention public service announcement to highlight VA's Be There campaign. As the Wounded Warrior Project pointed out, quote, If a treatment program does not offer a family or a caregiver component, and warriors go through clinical processes when they return home, it may leave the family or caregiver to feel left out in the dark about what occurred, end quote. We should all be doing all that we can to ensure family members and caregivers not only feel supported, but have access to much needed resources as they help their loved ones recover. In addition, I would encourage all of you to meet with both veterans who are suicide survivors and speak with families who have lost loved ones to suicide to better understand how we can work to end this crisis. Now, at this time, I'd like to recognize my friend and colleague, Dr. Rowe, for 5 minutes for any opening remarks that he may have.
Thank you, Mr. Chairman, and thank you for holding this hearing tonight and also shining a light on veteran suicide. Tonight's topic is the most important, most confounding, and the most heartbreaking one that we will discuss in this committee. While suicide is a tragedy, no matter where it happens, it is particularly painful when it occurs on the grounds of a Department of Veterans Affairs medical facility with help mere feet away. The last several weeks have seen 4 incidents of suicide on VA campuses, including one just today in Cleveland. My heart goes out to the surviving family members and friends of each of these veterans, and I want them to know that they are foremost on our minds here in this Congress. Their loved ones are a part of approximately 20 of our nation's veterans, active duty service members, and members of the National Guard and Reserve who die by suicide each day. That rate has remained largely the same since the 1990s, despite 2 decades of sincere effort from administrations on both sides of the political spectrum and substantial increases in funding, staffing, programs, attention, and support for mental health care and suicide prevention inside and outside of the VA healthcare system. Since 2005 alone, funding for the VA mental health care has increased 258% to a high of $9.4 billion in the most recent request. Unquestionably, too little progress has been made. Unquestionably, a business-as-usual approach to this crisis is not sufficient. To be clear, the tragedy of suicide is a societal one that is in no way unique to VA or to veterans. Let me just give you an anecdotal description of why I know that's true. In my state of Tennessee, when I graduated from medical school, we had Eastern State, Central State, and Western State mental hospital. Those are all gone. As I went across my district and held town halls and roundtables this past 2 weeks, I met an EMT who told me that he worked in the ER on weekends. One weekend, he had a man there who was in a room waiting for a bed in a mental hospital. He came back a week later, and the man was still in the emergency room. For seniors, we have to transport people from Sullivan County, Tennessee, you don't know where that is, but to Memphis, and I can tell you it's 500 miles away. We do not have the mental health infrastructure, not just for VA, but for our citizens in this country anymore, and it's something we're going to have to learn to deal with as a nation. Of the 20 suicide deaths per day among our nation's heroes, 14 have not received, as the chairman said, VA health care in the 2 years preceding their deaths. This is a clear indication that VA alone cannot solve this crisis. I commend President Trump for issuing 2 executive orders in the last 2 years to rally federal, state, and local government agencies as well as non-governmental organizations around this issue. I look forward to the hearing today about how those executive orders are working and how their impact will be measured moving forward. I'm also looking forward to delving into an important concept that Secretary Wilk and his team, including Dr. Stone and Dr. Franklin, who are both with us tonight, have been stressing recently, and that is that suicide is not exclusively a matter of mental health. It's quite a bit more complex than that, and solving it will require nothing less than harnessing the collective efforts of every community around in need long before the crisis point is reached. Tonight's hearing would be incomplete if it didn't include a frank discussion about the role each one of us can play in our districts to stem the tragic tide of veteran suicide, and about the deeper personal and societal issues such as loss of purpose, belonging, and connection that far too many Americans, not to mention veterans, are struggling with. Our goal should be more than just preventing suicide. It should be helping our veterans to live a life of meaning and joy. I would like to also caution us all in having that discussion to resist narratives that paint veterans as victims or a tragedy of suicide is insurmountable. We know from research and experience that treatment works and recovery is possible, and that is the principal message that I hope everyone takes home tonight with them. I'm grateful for all of our witnesses and audience members for being here this evening, and I yield back, Mr. Chairman.
Thank you, Dr. Rowe. Appearing before us tonight is Dr. Shelley Avanavoli. And she is with she's the Deputy Director of the National Institutes of Mental Health. Dr. Richard McCune. Excuse me, did I say your name correctly, Mr. McCune? McKeon. Dr. Richard McKeon, Chief Suicide Prevention Branch of the Substance Abuse and Mental Health Services Administration. Dr. Richard Stone, Executive in Charge, Veterans Health Administration, Department of Veterans Affairs. And accompanied by Dr. Keita Franklin, National Director of Suicide Prevention, Department of Veterans Affairs. And we'll begin first with testimony from Dr. Avanavoli. Dr. Avanavoli, you are recognized for 5 minutes to give your opening statement.
Thank you. Good evening, Chairman Takano, Ranking Member Rowe, and distinguished members of the committee. I am Dr. Shelley Avanavoli, the Deputy Director of the National Institute of Mental Health within the National Institutes of Health. It is an honor to appear before you today alongside my colleagues from SAMHSA and the VA. Given the troubling rise in the national suicide rate in the past decades, suicide prevention research is an urgent priority for the NIH. As the lead federal agency for research on mental disorders, NIMH's portfolio includes projects aimed at identifying who is most at risk for suicide, understanding the causes of suicide risk, developing interventions, and testing the effectiveness of suicide prevention services in real-world settings. In collaboration with our federal and private partners, we work to translate these research findings into evidence-based practices. Today, I want to highlight research that has identified promising suicide prevention tools ripe for implementation within healthcare systems. When used effectively and in combination, these tools may increase the number of lives saved among veterans and among all Americans. Healthcare settings are important for two reasons: access and opportunity. Nearly half of individuals who die by suicide had some type of medical visit in the 30 days prior to death, and around 80% did so in the year before death. In addition, about half of people who die by suicide had at least one emergency department visit in the year before death. NIMH-funded research has identified a growing number of evidence-based suicide prevention tools that can be used right now in these healthcare settings. I would like to walk you through a scenario that showcases how the healthcare system, using some of these tools, can identify more people at risk for suicide, provide effective treatment, and ensure appropriate follow-up care. So let's say you are depressed and feeling suicidal, but you haven't told anyone about these feelings. One day you have severe abdominal pain and you go to the emergency room. Your conversation with the doctor focuses on your physical pain, but because this emergency room screens all patients for suicide risk, the doctor asks you if you have had suicidal thoughts or attempted suicide. Our funded research shows that screening all patients doubles the number of people we can identify who are in need of help for suicide risk. So when you tell this doctor that you have been considering suicide, the doctor connects you with a social worker. The social worker asks questions to assess your level of risk, discusses treatment options with you, and works with you to develop a personalized safety plan. This safety plan describes approaches for reducing your access to lethal means, identifies specific coping strategies to decrease your risk, and lists people and resources that could help you in crisis. Safety planning is an evidence-based intervention, and we are currently supporting research on the best ways to deliver this in various settings and populations. As part of that safety plan, the social worker links you with a local crisis center that is part of the National Suicide Prevention Lifeline system. This crisis center works with your hospital to keep in contact with you by telephone over the next few months, a very high-risk time for suicide. An NIMH-funded study has shown that this combination of screening, brief prevention, and follow-up contact reduced suicide attempts in the next year by about 30%. A growing number of healthcare systems are implementing many of these evidence-based practices, but we know there's more we can do. Through the National Action Alliance for Suicide Prevention, the NIMH, SAMHSA, CDC, VA, and other public and private partners are working towards a goal of 0 suicide deaths in healthcare, in which health systems implement these and other evidence-based practices. The 0 suicide framework includes comprehensive tracking of patient outcomes so we can monitor progress and identify additional ways to save lives. Today, I've highlighted just some of the suicide prevention tools our researchers have tested in the healthcare system. We are committed to working with our partners and stakeholders to ensure these evidence-based tools are implemented and accessible to all. Moving forward, we will continue to provide hope by supporting research to prevent suicide. I want to thank the committee again for bringing us together, and I'm happy to address any questions you may have.
Thank you, Dr. Evidencebased. Dr. McKeon, you're recognized for 5 minutes to give your opening statement.
Thank you. Chairman Takano, Ranking Member Rowe, members of the committee, thank you for inviting the Substance Abuse and Mental Health Services Administration to participate in this extremely important hearing on suicide prevention for America's veterans. I'm Dr. Richard McKeon, Chief of the Suicide Prevention Branch at SAMHSA. An American dies by suicide every 11.1 minutes. Suicide is the 10th leading cause of death in the United States and the 2nd leading cause of death between ages 10 and 34. We lost over 47,000 Americans to suicide in 2017, almost the same number we lost to opioid overdoses. For each of these tragic deaths, there are grief-stricken families and friends, impacted workplaces and schools, and a diminishment of our communities. SAMHSA's National Survey on Drug Use and Health has also shown that approximately 1.4 million American adults report attempting suicide each year, and over 10 million adults report seriously considering suicide. As painful as these numbers are, our concern is intensified by the CDC's report that suicide has been increasing in 49 of the 50 states, with 25 of the states experiencing increases of more than 30%. While federal efforts to prevent suicide have been steadily increasing over time, thus far they have been insufficient to halt this tragic rise. We can only halt this rise nationally if we are also reducing suicide among the estimated 20 veterans a day who die by suicide, including those not in the care of the U.S. Department of Veterans Affairs. All of us must be engaged in this effort, and for this reason, SAMHSA includes language in our suicide prevention funding opportunities, prioritizing veterans, and has worked actively with VA on suicide prevention since 2007. While we have not as of yet been able to halt this tragic rise, we have seen that concerted, sustained, and coordinated efforts can save lives. One area where such a concerted national effort has been made is youth suicide prevention. Cross-site evaluation of our Garrett Lee Smith Youth Suicide Prevention grants has shown that counties that were implementing grant-supported suicide prevention activities had fewer youth suicides and suicide attempts than matched counties that were not. However, this life-saving impact fades 2 years after the activities have ended. This underscores the need to embed suicide prevention in the infrastructure of states and communities. Congress has also provided SAMHSA $11 million to focus on adult suicide prevention, with $9 million appropriated to the Zero Suicide Initiative. This is an effort, as my colleague has expressed, to promote a systematic, evidence-based approach to suicide prevention in healthcare systems, using the most recent findings from controlled scientific studies as part of a package of interventions that moves suicide prevention from being a highly variable and inconsistently implemented individual clinical activity to a systematized and prioritized effort. It uses the most recent science on screening, risk assessment, safety planning, care protocols, and evidence-based treatment. We've also been working through all of our suicide prevention grant programs to improve post-discharge follow-up, since multiple studies have shown that rapid contact after discharge from EDs and inpatient units is a time of high risk. The SAMHSA Suicide Prevention Program that touches the greatest number of people is the National Suicide Prevention Lifeline, a network of 165 crisis centers across the country. The National Suicide Prevention Lifeline includes a special link to the Veterans Crisis Line, which is accessed by pressing 1. Last year, more than 2.2 million calls were answered through the Lifeline, and that number has continued to grow at a rate of about 15% per year. However, the increasing call volume is also straining the Lifeline system of community crisis centers, which are responsible for responding to calls. SAMHSA and the VA have been working to prevent suicide. More recently, SAMHSA and VA have worked together to fund a series of mayor's challenges and governor's challenges to prevent suicide among all veteran service members and their family. We have convened cities and states and policy academies and implementation academies to promote comprehensive suicide prevention for veterans. Multiple public and private partners are engaged in this effort. As an example, in the Richmond Mayor's Challenge, the McGuire VA Medical Center and the Public Mental Health Center, Richmond Behavioral Health Authority, have developed a coordination and referral process to assure that veterans at risk don't fall through the cracks between VHA and community system. That work is now being implemented elsewhere in Virginia as part of the Governor's Challenge. We believe that this type of strong, continuing interdepartmental effort that incorporates states and communities as partners is necessary to reduce veteran suicide. In summary, SAMHSA is engaged in an unprecedented amount of suicide prevention activities, but we know we need to do more to play our role in halting the tragic rise in loss of life we are experiencing across the country. In particular, we know we need to be engaged in a strong, continuing, collaborative effort with the Veterans Administration and others to reduce suicide among our nation's veterans. We know we must be constantly looking to improve our efforts and to learn from both our successes and our failures. We owe it to those who have served this nation and to all those we have lost, as well as to those that love them, to continually strive to improve until suicide among veterans and among all Americans is dramatically reduced.
Thank you, Dr. McKeon. We will now hear from Dr. Stone, who will be recognized for 5 minutes to give his opening statement.
Good evening, Chairman Takano, Ranking Member Rowe, and members of the committee. I appreciate the opportunity to be here to discuss the critical work VA is undertaking to prevent suicide among our nation's veterans. I am accompanied today by Dr. Keita Franklin, Executive Director of the VA Suicide Prevention Program. Suicide is a serious public health tragedy that affects communities across this nation, and recently this tragedy has occurred on the grounds of our VA healthcare facilities. In the last 6 weeks, 6 veterans have ended their lives on our healthcare facilities. Our facilities are designed to be places of safe haven for those who defended our nation. Although less than 0.5% of suicides occur at both VA and civilian healthcare facilities, these events highlight the important discussion that we will have here tonight. All of us at VA feel these losses as we have dedicated our professional lives to provide health care and enhance the resilience of our nation's veterans. The 2018 National Strategy for Preventing Veteran Suicide is a multi-year strategy that provides a framework for identifying priorities, organizing efforts, and focusing community resources to prevent suicide among veterans. This approach has 4 key areas. First, primary prevention that focuses on preventing suicidal behavior before it reaches the level of individual self-harm. Second, a whole health approach that considers factors beyond just mental health. Third, application of data and research that emphasizes evidence-based interventions, and fourth, collaboration that educates and empowers communities to propagate suicide prevention efforts beyond the VA. These efforts should move us from a crisis intervention focus to one that enhances the relational skills and resilience of our heroes. We know that an average of 20 veterans die by suicide every day. This number has remained relatively stable over the last several years. Of those 20, only 6 have used VA health care in the 2 years prior to their death, while the majority, 14, have not. In addition, we know from national data that more than half of Americans who died by suicide in 2016 had no mental health diagnosis at the time of their death. This is also true for our veterans. We also know that a massive expansion of VA mental health providers and increased mental health access has done little to reduce the total number of suicides among America's veterans. While there is still much to learn, there are some things that we know. Suicide is preventable, treatment actually works, and there is always hope. Maintaining the integrity of VA's mental health care system is vitally important, but clearly this is not enough. VA alone, without the help of all of you, cannot end veteran suicide. The VA has expanded its suicide prevention efforts into a public health approach while maintaining and expanding our crisis intervention services. We ask all of you to help, and we appreciate the public service announcements many of you have already recorded. VA is expanding our understanding of what defines healthcare by developing a whole health approach that engages, empowers, and equips our veterans for lifelong health, improved resilience, and improved well-being. VA is uniquely positioned to make this a reality for our veterans and for our nation. This effort is about enhancing individual resilience. On March 5th, 2019, the President signed Executive Order 13861, a national roadmap to empower veterans and end suicide, in order to improve the quality of life for our nation's veterans and develop a national public health roadmap to lower the veteran suicide rate. This executive order will further VA's efforts to collaborate with partners and communities nationwide and to use the best available information to support all veterans. We must partner with, empower, and energize all communities to engage veterans who do not use VA services. We are committed to advancing our outreach, prevention, empowerment, and treatment efforts, and will continue to improve access to care. Our objective, however, is to give our nation's veterans the top quality care that they have earned, wherever and whenever they choose to receive it. Mr. Chairman, this concludes my statement. My colleague and I are prepared to respond to your questions. With your tolerance, sir, I would like to do something that I did before, and I would like everyone that has not done so already to take your phone out and to type in the Veteran Crisis Line, 1-800-273-8255. 1-800-273-8255. You will be prompted to press 1 if you are a veteran, and you'll be connected to our professionals. You can also text 838-255, 838-255 to connect with a VA responder. Mr. Chairman, thank you.
Thank you, Dr. Stone. Let me say that Dr. Avenivoli Dr. McKeon and Dr. Stone's full written testimony will be included in the hearing record. Let us move on to the questions. I'll begin with myself. I recognize myself for 5 minutes, and my first question is for Dr. Stone. Dr. Stone, VFW's statement provides an example where a veteran sought immediate treatment at a VA mental health clinic because, quote, she feared that she would take her own life, end quote. The front desk clerk told her that she couldn't be seen immediately because she had completed a mental health appointment the previous day, and the next available appointment wasn't ready for a week. Thankfully, this veteran survived despite failing to receive the appropriate care. In contrast, at VA hospitals throughout the country, employees have responded by saving 240 veterans' lives when they walk through the hospital doors needing help. But let's put ourselves in the shoes of this woman for a moment. That interaction with the front desk clerk, or a nurse, or a police officer could have led her life to her life being saved, or led to that veteran going to the parking lot and committing suicide. How should the front desk clerk have responded? And how is every VA employee trained to recognize the signs of a veteran in crisis?
Mr. Chairman, clearly this veteran should have been seen. I'd be happy to review the events related to that if they can be provided to me by your staff. Secondly, let me reference the bill that was created for the veteran that you referenced. Certainly, I am very pleased that this veteran was admitted for a 2-week period of time, or at least that's my understanding. I'm deeply disappointed that the first I've heard about it is about this bill is in this hearing. I think it would have been helpful when I had breakfast with that VSO 2 weeks ago and discussed suicide. If we could have brought this to my attention, we could have alleviated 2 weeks of suffering for that veteran and his family. We will be happy to work with this. I can only assume that the lack of eligibility for payment for those services through our normal budgeting reflects something in the veteran's background that made him or her ineligible. But what should that front desk clerk have done? That front desk clerk has in all likelihood gone through SAVE training, which is training that we give to our non-clinical personnel to recognize issues. That veteran should have been seen and then evaluated by a medical professional. It is notable that our police officers go through 30 hours of mental health training in order to recognize veterans in crisis. They also go through approximately 20 hours of actual scenario-based study in which they demonstrate their capability to diffuse and de-escalate situations. That has been recognized at our training academy, and a number of other federal agencies and police agencies have sought that training from us. I'll defer to Dr. Franklin if she has additional comments.
The only other piece I would add is that I appreciate the context of the question with regard to the front desk, because everybody has a role when it comes to preventing suicide, and anybody in the hospital system can do the right thing, and we're teaching them that through the training. We're teaching them to know the signs, know the symptoms, know what a risk is, and to take action at their level, regardless of what level that is.
Dr. Franklin or Dr. Stone, if I were to ask any VA employee at a VA hospital how they should respond when a veteran in crisis walks through the door, what answer would I get?
The answer should be yes. The answer should always be yes, and we welcome veterans to be seen. Every one of our sites, more than 1,000 sites, has same-day access for mental health services, regardless of veteran status.
Is every employee trained to recognize the signs of a veteran in crisis and to treat that veteran with compassion and respect?
Yes.
So, Dr. Stone, I appreciate that you brought up earlier the issue with the $20,000 hospital bill. My question was, how does VA prevent veterans from relapsing into crisis upon discharge, including the way in which VA bills veterans for the care they receive? And my question would be, wouldn't sending a veteran a $20,000 hospital bill send a veteran into crisis and create another barrier for care?
We certainly know, and this is part of my opening testimony, we certainly know that many of the issues facing veterans that lead to suicide relate to relational problems, relationship problems, as well as financial problems. And it's deeply troubling that we would generate this bill if there wasn't a secondary insurance that should have been billed.
So it's very important that VA is able to exercise its role as a central coordinator of care in these cases.
Absolutely, sir.
My time is up, and I'd now like to turn to Ms. Radewagen for 5 minutes.
Thank you, Mr. Chairman, and thank you, Ranking Member Dr. Rowe, for holding this very important hearing. I also want to welcome the panel. Thank you for all you do. My question is for Dr. Stone, and if anyone else has any comments, that would be appreciated. There has been a tremendous amount of attention devoted to the 3 recent incidents of suicide on VA campuses. Do you see any connection among these incidents, and do you have any evidence that they are symptoms of an increase of suicide among veterans, either in general or on VA property?
Each one of these incidences is a tragedy, and each one is an individual that we've lost. What's difficult to understand is that a number of these incidences have occurred in individuals that we hadn't seen for a number of years, but yet they arrived on our campus and underwent an act of self-harm resulting in their death. Clearly, as the ranking member pointed out in his comments, the fact that help was a few feet away is deeply troubling. But yet, even if we fix that problem, 99.6% of veteran suicides are not occurring on our campuses. Now, what do we know? We know that America has a problem on inpatient services, especially in psychiatric units, when there are not door alarms and wait alarms that can prevent suicides. We learned that lesson tragically in West Palm Beach in less than a month ago when a veteran actually timed our nurses walking through to check on them and then committed an act of self-harm resulting in his death immediately after the nurse walked through to check on him. The lesson from that is that we're replacing every door across our system with weight sensors. Now, is it perfect? No, but it's the best that we have in order to correct this issue. What else have we learned? We've learned that some of these veterans come to our campuses because, and we know this from the notes that they've left, that they know they'll be taken care of, and they know their families will be taken care of. There are those that would like to indict the VA in this process. And I would caution you that this is not as easy as me having just a few more policemen to go through the parking lots or the parking structures. But this is about a whole of society approach that reconnects veterans that are intensely lonely and with a feeling of hopelessness that results in these acts of self-harm.
Does anyone else have any comments? My time is running out, but thank you, Mr. Chairman. I yield back.
Thank you, Ms. Radewagen. I now would like to recognize Ms. Brownlee, who chairs our Veterans Health Subcommittee.
Thank you, Mr. Chairman. And I wanted to do a quick follow-up to your line of questioning. Dr. Stone, you gave some very positive responses to the chairman's questions in terms of what the VA does vis-a-vis responding to a veteran in crisis. My question is, how do you know that you're 100% correct?
I can know because we tabulate on our training management system the amount of training that's been done. Now, we certainly have new employees coming on board that need training, but you would think that with the large amount of redundancy in our system, that there would be the possibility that each veteran would be able to be taken into our care effectively and without being turned away.
So training is enough in terms of ensuring that we have a 100% positive response to a veteran in crisis. I understand that there's turnover and that sort of thing, but it seems to me as though there needs to be more of that to know site by site that those things are actually being executed. That's my concern.
Congresswoman, thank you, and I appreciate it. It's my concern also. And I think that's why I mentioned amongst our police officers the ability to actually demonstrate empathy, to be able to demonstrate the ability to de-escalate a crisis situation is absolutely essential.
Thank you. Another question I had, the doctor from NIH laid out a program, an evidence-based safety program, I think that you called it, but basically to quickly summarize, it's screening all patients, then a social worker drilling down a little bit more in terms of screening, and then obviously if that screening tells the professional that a veteran is in crisis, then linking she or he with a crisis center, perhaps within the VA, perhaps within the community, and I think we all agree it's a community effort. So evidence-based program, effective, good results. Is this what we're doing in the VA every single day, screening every single patient, having a social worker do the screening, and then, if need be, linking that veteran to services?
Yes, Chairwoman, that's exactly what we're doing. We've received those results from NIMH, and we've implemented that enterprise-wide, exactly those three methodologies. Not only screening in mental health, but screening in every single clinic across the entire VA. If somebody gets seen in podiatry, they're getting a screen on suicide, make no mistake. And the safety plans across the board. This past year, we implemented a standardized safety plan protocol so that we could make sure that every safety plan that was done is done the same and is done with a high degree of rigor and evidence to the exact model that was briefed by my colleague, and follow-up contact through caring outreach, exactly following the research model. Yes, ma'am.
Thank you. And the last question I had was on military sexual trauma. So it's my understanding, it's been a while since I read the report, but there was an OIG report, I think it was in 2018, that talked about MST claims. And the report, if I recall it correctly, said that 60% of the MST claims were incorrectly denied, so that women and men perhaps were not receiving the benefits they needed. Obviously, MST is very much linked to the topic that we're talking about this evening. If you could tell me, can you respond to that and let me know what the VA is doing about it?
Congresswoman, certainly I represent VHA, not VBA, and I appreciate the question. And just to make sure that I have this right, we will check and get back to your staff to make sure that we answer this correctly. But my understanding is those denied claims are now all being reviewed to assure that they are accurate.
I would like a follow-up if you can provide. I think it's of your interest, it's of our interest, obviously. I understand it's under VBA, but you know, MST and the link here, I think is very important, and I think we need to actually have very firm answers. And my time is about to run out, but you mentioned in your testimony about a national network of women's health champions, which sounds to me like a new program. I don't have time to ask the question today, but I haven't heard about it and very interested to understand what it's about. I yield back.
Thank you, Ms. Bradley. I now recognize Mr. Belarakis for 5 minutes.
Thank you very much, Mr. Chairman. I appreciate it. Thank you for holding this hearing. I want to thank Dr. Rowe as well. Thank you for your testimony. Appreciate it so very much. Dr. Franklin, quickly, what about screening more intensely for suicide awareness at DOD? Any comments on that?
Screening more intensely with DOD?
DOD, yeah, yeah.
Yes, we have there was an executive order that was pushed out in this past year, not the one that Dr. Stone mentioned in his testimony, but an earlier one. And this executive order calls for increased screening from DOD so that when troops are leaving the active duty side, they have eyes on by a medical provider, and those results are immediately pushed over to our mental health teams over on the VA side, so that there's an accurate view on the service member's mental health status before they leave active duty.
Okay, very good.
Let me add just a little bit to that. I think this is absolutely correct, but in that first executive order, the ability for us to interact with a service member in the year before they leave active duty is absolutely essential, and the authorities you've granted us in allowing us to see service members for that first year after they come off active duty is an absolute risk reduction. I would ask the committee to take a deep look at the work that's been done since the late 1990s in the Air Force that has actually integrated resiliency, relationship-based training, and suicide awareness amongst all active duty and reserve members of the Air Force. The Air Force has not seen the increase in the number of suicides that a number of the other uniformed services have. So this interaction and potentially modeling after the Air Force training is absolutely essential.
Very good. Well, I'd like to work with you, sir, on some legislation with regard to that, because I think that would make a big difference. I really do. Let me ask another question. I do have some prepared questions too, but I don't know, we don't have a lot of time. Can you tell me, and you may not have some statistics on this, but prior wars, prior eras, let's say the Vietnam era, even going back to World War II, give me some statistics with regard to suicide rates. How do we compare to what's going on today, the 20 a day, which is obviously one is much too high as far as I'm concerned. Can you give me any stats with regard to that? For instance, the Vietnam era, as far as the suicide rate is concerned.
Yes, absolutely, Chairman. The data collection has gotten better over the years, so sometimes it's difficult to compare data across war efforts. We've only recently gotten a lot more savvy with our data and surveillance efforts. But what I will tell you is that when we look at our current effort, we see our highest rate of suicide right now amongst 18 to 34-year-olds, when you look at the rate per 100,000, and we see our highest raw number amongst men over the age of 55, which we suspect comes from that other era, or that other war effort. And so we also know that we have more veterans in that group or in that category. And so that's what I offer, and I turn it back. Dr. Stowe may have more context.
So with regard to, how about percentages? You say you have more veterans in that category, but how about percentages?
So 21%.
I mean, we're spending more money, we have more programs, but evidently it's not doing any good.
So 21% of the suicides that we experienced in 2016 were in veterans over 75 years old.
All right, thank
When
you.
I add the 55 to 74 to that first group I mentioned, it adds up to over 60% of the suicides amongst veterans in this nation. Clearly, we need to recognize the fact that of the 20.4 million veterans in this nation, 77% have experienced combat. And the long-term effect on these veterans cannot be underestimated. Now, I grew up in a generational home. Multiple generations had been in that home. Everybody on that street were generational homes. I couldn't walk out the front door as a young child, but yet I had 20 moms that were up and down that street. Just think about the neighborhoods that each of us live in today and recognize the isolation that many of us feel. I've lived in my current neighborhood for 4 years. I know the neighbors on either side. I've been in their homes. No one else. Counter that to on-base housing that I experienced on active duty. When my family and I moved into a home, every single family in the neighborhood came to bring us food, to make sure we were all right, did we need anything, and every weekend after that for weeks, we were welcomed into their homes until we became firm members of that community. This is a profound difference that we're seeing in all age groups of veterans. Certainly the 18 years of combat that we've experienced in the current environment has taken a tremendous toll on veterans under age 35. But make no mistake that the increased suicide rate amongst veterans affects all age groups.
Thank you, Dr. Stone. Thank you. Let's try to keep our comments within the 5. We have a lot of people to get through, but I allowed you to go on because it was so compelling what you were saying. Let us move on to Ms. Rice for 5 minutes.
Thank you, Mr. Chairman. And thank you all for coming here to testify tonight. So I want to talk about an issue that I don't think that we can adequately address the issue of suicides amongst veterans without talking about guns, firearms. If you look at, there's no question that firearms are one of the most common means of completing suicide among the general population, and 69% of veterans have completed suicide via firearm. Women veterans are also more likely to utilize firearms in the attempt and/or completion of suicide than their civilian counterparts. It's been proven that restricting access to firearms may reduce suicide rates. So this is for anyone on the panel. Has the VA studied gun violence in the veteran population? What research is currently available on gun violence in connection to suicide? I'm well aware that we as a body, Congress, has not been willing to fund a study to look at the overall reason for the epidemic of gun violence in this country. But since we're talking about the VA, I'm specifically asking about the VA. Is this an issue that warrants more research to shed light on why firearms are the most common means utilized? And what resources does VA offer to veterans that may choose to limit their access to firearms? So anyone who wants to answer that.
Well, to put it in a national context, let me mention a couple of things. So 51% of all suicides in America utilize a firearm. So it is clearly a very important issue. The collaborative safety plan that Dr. Evidencebased spoke to includes as part of that paying attention to access to lethal means when working with an individual who is suicidal. That frequently includes firearms, can also include things like access to large amounts of pharmaceuticals or other dangerous substances. SAMHSA, through our Suicide Prevention Resource Center, has an online course on counseling about access to lethal means. Again, this is within the context of someone who's suicidal and trying to reduce access to lethal means on a temporary basis. And then finally, I would mention that a number of our SAMHSA grantees are doing work with firearm-owning groups and things like what it's called the Gun Shop Project, working with them and with other groups to try to have a collaborative effort to educate about suicide warning signs so that people know how to respond.
And the only other thing that I would add from the VA side, we're working hand in hand with SAMHSA on many of those initiatives that Dr. McEwen spoke about. We also train our mental health providers with a special training on access to lethal means and how to talk with veterans about this issue. We do have a partnership with the National Shooting and Sports Foundation, and this is a partnership that helps us execute trainings in local communities with gun shop owners on signs and symptoms of suicide risk. And then we do work on this issue around putting time and space between the person at risk and any means that's lethal, and certainly firearms are the top means in our population, as you note, but equally so medication and a host of other issues around this topic.
Dr. Stone, you mentioned before, you used the word ineligibility. And to me, I just think it is the most insane policy that there is any man or woman who wore the uniform of this country and is, I don't care what they did, is ineligible for some kind of, for access to health care. I wonder, Dr. Stone, if you can tell us what specific risk other than honorable discharges represent because of their limited access to VA mental health care services, specifically women veterans who are more likely to have experienced MST, are also more likely to have received a bad paper discharge as retaliation for reporting MST before the 2-year mark when they would be eligible for VA healthcare. So I think this is an issue that we need to talk about in terms of, I just don't think that there should be a veteran and ineligibility should never go hand in hand.
I think, Congresswoman, you're exactly correct. And one of the big problems that we had, as the chairman identified in his opening statement, is never activated guardsmen and reservists. They'd never been called to federal service, so technically they're not a veteran. And I'm not eligible to welcome them into the system. Now, we've tried to overcome that by using our vet centers and combining, and we've worked very successfully with the Guard Bureau and the Army Reserve to try and move our vet centers on a mobile basis into drill weekends. But many of the suicides we're seeing in never activated guardsmen and reservists are between age 35 and 54. So they're long since their service days. And how to reconnect with them or to give us the authority to engage them. It seems to me that if I can accept veterans with other than honorable paper, we ought to be able to accept the never activated Guard and Reserve, who account for about 2.5 to 3 of the daily suicides that we're seeing.
Thank you, Dr. Stone. I think it's a conversation we should continue to have, and thank you, Mr. Chairman.
Thank you, Ms. Rice. Those are really great questions. Mr. Boast, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Thank you for having the hearing tonight. I think just real quickly, there's something that I should bring up. You know, because it came up during the last questioning. You know, losing one veteran just suicide is tragic, and I know none of us take it lightly. That being said, the veteran's Second Amendment right, and the ability to take that right away from them will not stop one of them from attempting suicide, and in fact, may discourage them from seeking help through the VA or through other means if they believe that they might lose that right. And I think that's a concern. It depends on where you're at in the country, but I know where I'm come from, and many of them have expressed that concern to me as well. We're all committed to preventing suicide, and I'm dedicated to ensuring that we are appropriately educating at-risk service members and veterans and their families about firearm safety and providing them meaningful support to help them overcome the struggles that they face. But as I said, I do believe we want to be very, very careful when we go down that road. But Dr. Stone, you actually, I think you answered part of this, but I'd really like to know, because you referenced in your testimony the President's executive order from last year, and I wanted to thank him for signing that, but ask you, what, if any, outcomes and lessons have been learned from the EO since it was signed, especially when the veterans are being screened from benefit from the VA and going on through the TAP program at DOD? What are we gleaning from that?
What we're learning, and I mentioned a bit about the Air Force experience that is incredibly intriguing, but what we also learned is that the more veterans and service members learn about our services, the more they engage us. And it is the absolutely right thing to do for us to be engaged with them well before they get out of uniform. Now, certainly when you're sitting at the discharge station getting ready to get out, you don't want to hear very much. But in that 6 to 12 months before, it is time for us to engage. And the active services have all been very gracious in giving time for our staff to come in and talk about access as well as risk for that service member in the year after they leave service. You know, I discussed earlier the difference in American society on the civilian side versus American society in uniform. These are dramatic changes for the service member who may have experienced 10, 15, or 20 years in uniform.
and believe me, I'm not criticizing when I go down this next path, okay? I'm trying to figure it out as a member of this committee, and I'm sure this whole committee is asking this. You know, the BA is, but once again, back before us and telling us that combat veteran suicide is a top priority for the BA. As your budget continues to increase, suicide prevention money, we're giving more money towards that. But what actual results can be seen from the funding level that we're putting out there? We're not changing it. We're still at that 20 a day. We've got to come up with the ideas that truly change this. Not only, we've got to figure out that if we're increasing money, we're not changing it, we're increasing programs and we're not changing it, how do we become really effective and bring those numbers down? Now, I know that you brought up the fact of the age, and the concern of the age, too, is where are we at when they commit suicide? What other things might be going on in their lives? Do we monitor that? Do we know those statistics? And how do we bring it down? Because every year we can come back and talk about it, but if we don't change the numbers, and we can raise the money every year, but if we don't change the numbers, we're not helping them.
Certainly, I can't disagree with your statement, Congressman, but I think the message here is that if this was 10 years ago, this would have been a $4 billion budget, and I'd have half the number of mental health providers that I have today. We have same-day access to mental health services, but we haven't changed the numbers. Now, there are those that would argue that maybe we have. Maybe this would be worse as a crisis if we didn't have 24,000 mental health professionals ready to see you today as a veteran. If, in fact, this is not the answer, then we have some hard looks at each other and hard looks at ourselves in the mirrors about what society has become. And I mentioned that in the generational home that I mentioned earlier. These are very tough discussions to have. We do know that the incredibly high rates of military sexual trauma, intimate partner violence, substance abuse, mental health disorders lead to a dramatic escalation in female veterans, as was mentioned by some of your colleagues earlier. We know also, amongst all veterans, that it is in the 2 weeks before becoming homeless, the rates of suicide go up dramatically. We also know that for veterans that are involved with the justice system, the month after they've been incarcerated, after they get out from incarceration, dramatic levels of suicide. But this is true across all of American society. Frankly, that's a worldwide phenomenon.
Thank you.
Thank you, Mr. Bost. I now recognize Mr. Lamb for 5 minutes.
Thank you, Mr. Chairman. Dr. Stone, I want to thank you for mentioning the whole health programs in your testimony and for being a supporter of those. I also have been struck by the potential in the VA's whole health program, and I got the chance to visit the program at the DC VA hospital, I believe it was last summer. And it's just a really promising area, and I just commend the VA for pursuing it and being innovative and risk-taking with that. And what struck me about it was not just the value of the services themselves. I think what we saw was acupuncture, meditation, yoga, and a couple other things. But you used the term empowering veterans, and what it really did was it gives veterans an active role in managing their own health care. It basically gives them a bunch of great, non-traditional, somewhat unusual options and says, pick from these yourself, and whichever one you like or you find valuable, keep coming back. And that was how they were running it. And you could tell that from that, a little community arose, and some of the same veterans would keep coming back to the same classes as they were able to, and they got to know each other and were looking out for each other and everything. And I think that, when we were there, it was mostly older veterans, but I think there's a lot of potential to use a program like that to attract some of the younger veterans into the system, because military members on active duty now are being trained in some of this same stuff. DOD has been pretty good at getting some of these things out there, so I think people are more used to it. So I have introduced legislation to try to expand the availability of whole health within the VA, and I'd love to have your support on that. But I was just hoping that either you or Dr. Franklin could talk about any connection you believe exists between the availability of the whole health programs and your suicide prevention efforts, how those can go hand in hand. Thank you.
As we modernize the VA, Congressman, one of the 10 lanes of effort is to expand across the entire enterprise the whole health model. One of the things our colleagues have delivered in knowledge is an understanding of the role of physical exercise or the participation in team-based sports at any age as a dramatically preventative activity in reducing the suicide risk. And I'll defer to Dr. Franklin if she has other comments.
I appreciate your thoughts on the whole healthcare, and I'm eager for us to execute it across the enterprise. It started with the 18 flagship entities, one of which you may have visited, and it's well underway for full execution across the enterprise. And this notion of focusing on the social determinants of health and thinking about veterans in the context of biological, sociological, psychological, and spiritual, and allowing them to drive their care is the future of the organization. So I definitely appreciate it.
Thank you both for your work on that, Mr. Chairman. I yield back.
Thank you, Mr. Lamb. Mr. Bergman, you're recognized for 5 minutes.
Thank you, Mr. Chairman, and thanks to everyone for being here. This is a subject that I know all of us take very seriously. And I'm not sure which one of you gave the following stats, so I apologize for that. Second leading cause of death in the age group 18 to 34. What's number 1, 3, and 4? Any ideas?
Well, in that age group, number 1 is accidents.
Okay.
And 3 is homicide is either 3rd or 4th. But I don't remember exactly. We can certainly get that for you.
Okay, well, and also in that, regardless of what's 1, 2, 3, and 4, is there, from a gross standpoint, big numbers, not finite data, is there any huge percentage difference? Now, accidents are accidents, but any significant percentage differences in like 3 and 4, which is all of a sudden just a drop off?
Well, I think that one thing to remember, for example, is that while accidents may be at times very random, they are.
I don't want to. No, I don't want to waste time on accidents.
Okay.
That's okay. We try. And the bigger point here is a relative perspective of where it fits in causes of death as we talk to people and talk to other entities and figure out where to put, if you will, finite resources towards solving problems. An example: isolation. We know causes potential suicidal ideations. Back when some of us with gray hair entered the military, there were military barracks. You had the communal living where you had your bunkmate. You had that. Now we have private rooms, if you will, once you reach maybe E4 or E5, and that idea we're not able to have eyes on our fellow military members regardless. So, differences when it comes generationally to when it talks about the community, the neighborhoods. You know your neighbors or you don't know your neighbors. Well, do you know your platoon mates? Do you know the people after you leave? Are there the associations? So I think there's differences societally here as we look at dealing with mental health. State-sponsored programs. Do states have different programs that you can refer to as examples of how it's being done very well? Some states versus others. Not that we need to know, but are there best practices being shared when it comes to, the one size fits all when it comes out of Washington D.C. may not resonate in in northern Michigan or isolated areas or somewhere where are more rural than urban. But are there any things you do to compare and contrast and take best practices?
I would mention a couple of things. Many states are making strong efforts for suicide prevention. An example of that is what's called the Colorado National Collaborative, which CDC has also been very engaged in. The idea there is to try to promote suicide prevention in a comprehensive public health way and to bring it down to the local level. And again, it's something that's being driven by those states and communities. There is federal funding that is being utilized.
I guess the question, because again, my time is running short and I got a couple quick questions, but as long as we can see that best practices are being captured and then put out so that we gain from it, not just a one-size-fits-all perspective. And as far as the requirement for veterans to make contact within a year after leaving active duty, did I get that right? Okay, any idea what percentage of those veterans are still in the individual ready reserve? Because that's, when you talk about that 18 to 34 group, a lot of those are still in that time frame where they have a 4-year commitment. Who's doing that? How's that contact being made?
So we've talked to both the Army Guard and the Army Reserve, who have the largest reserve, individual ready
Yeah, but they're not in. When a young soldier, sailor, airman, Marine who leaves active duty, they're under DOD, they're Title 10 with their responsibilities, not Title 32. So the point is, who's taking care of those folks in the individual ready reserve?
That's very difficult to say.
Okay, well, you can take that for the record, and I would suggest, Mr. Chairman, I know my time is up, that would be an interesting, maybe for a roundtable for us to talk about that, because there's some significant differences there, especially given the age group that we're talking about here is the number 2 leading cause of death. And I yield back.
The point is well taken, Mr. Bergman, General Bergman, and it's been noted by my staff, and I take your suggestion. Mr. Brindisi, you are recognized for 5 minutes.
Thank you, Mr. Chair. Thank you, Dr. Stone, and to all our witnesses who are here today. I just spent a couple weeks back in the district and had a chance to tour some of our VA clinics in anticipation of this hearing coming up. I had the opportunity to ask the professionals at our VAs what are some of the things that we can do collectively to try and reduce suicide. And one of the things that was mentioned to me on several occasions was focusing more on that transition period out of Department of Defense active duty life and into the VA, and how we can do a better job coordinating. And I know we touched upon this a little bit, but are there ways, because my understanding, I'm not a veteran, but as you're coming out of active military, there's a lot of information that's thrown at you. It's one of the VA professionals actually likened it to a phrase I'm pretty familiar with, drinking from a fire hose. So what can we do? What kind of coordination efforts are taking place between the DOD and the VA? And is the DOD being cooperative in assisting the VA reach a veteran in that 6 to 12 month period prior to getting out of active duty?
The answer is yes. DOD is being great partners in this process. We'd always like to have more time to spend with the veteran, because the more time we spend with the veteran, the more likely they are to engage with us after they get out of service. I think secondly, are we effectively outreaching in that year after they get off of active duty? You have funded us very graciously, and we'll spend about $200 million this year in outreach efforts of various types, everything from electronic billboards to websites in which we're reaching out to even direct mailings. We mailed 500,000 letters to Other Than Honorable in December of last year, and we're able to capture well over 1,000 veterans to come in and see us. But it all depends on the individual, and it all, most importantly, depends on when the individual is really open to hearing our message. There is no doubt that we are the most integrated healthcare system when it comes to mental health. And the ability for us to interact with that veteran and provide integrated ongoing services is what's essential to their well-being in the future.
Thank you for that. And one of the interesting programs that I'd heard about from the VA region that I represent, I'm not sure if you're familiar with something called Freeze the Keys. Have you heard of this before?
I have not, but Dr. Franklin may have.
No.
Okay, so touching a little bit upon our conversation earlier about gun violence. So in the Syracuse VA region in upstate New York, they told me about this program that they are implementing called Freeze the Keys, where they will take the keys of a gun storage cabinet. A veteran may own a firearm that they keep in a storage cabinet, and they keep that storage cabinet locked. And they will take the keys from the storage cabinet and put it into a cup, and then put water in the cup, freeze the cup in a freezer. So when the veteran has the impulse that they may want to go get their firearm to commit suicide, they actually have to get the key out of that frozen cup, which creates more time for them to think about the act that they may take. And on this cup is a picture perhaps of a loved one, perhaps of the Veterans Crisis Suicide number, just something that they're doing where they think it may give more time, because it's an impulse, it's a quick impulse when you want to take your life. This may give a little more time for them to think about it before they actually are able to get the key out of the ice and go to the storage cabinet, get the firearm, and commit suicide. Seems like a good
Congressman,
practice.
One of the most deeply troubling facts in survivors of suicide is that in about 25%, the distance between the decision to commit an act of self-harm to actually committing the act is 5 minutes. And in about half, it is less than 60 minutes. Anything that puts distance between that decision and attempts to de-escalate the crisis has value. Whether putting keys and freezing them in, putting a picture of a loved one, or simply the phone ringing of a loved one saying, "I've been thinking about you," is a chance to de-escalate.
Thank you. I certainly would encourage you, because it just seemed like a wonderful program that they're utilizing up in the area that I represent. Perhaps it's a practice that maybe we could use across the country to help give more time to make that decision.
Thank you, Mr. Mendesi. Mr. Banks, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Dr. Stone, I have a quick question for you at the outset. What are you and the Secretary doing to create a culture of urgency at the VA and the VHA to deal with veteran suicides?
Congressman, I think there is a culture of urgency. I think this is the Secretary's and my #1 priority, is to do everything we can to reduce or eliminate veteran suicide. But as I said in my opening comments, we cannot do this alone. And we need the entirety of American society to dedicate themselves along with us and support us. It's, as I mentioned to your colleague, a telephone call to a veteran or somebody that you haven't seen, somebody from your faith group to pick up the phone. One of the things we recognize in your state has some of the lowest suicide rates in the nation, both among civilians and veterans. There's something unique that goes on in your state. It may be the small towns, it may be the faith-based communities, but there is something unique that the suicide rates in your state are dramatically lower than a lot of other areas. The other thing we recognize is in highly populous states like California and New York, there are reduced suicide rates over the more rural states. If I go to Montana or South Dakota, the rates are dramatically higher. Is this about loneliness? Is this about isolation? Is this about being disconnected? The answers to all of those are yes.
Can you point to, for our benefit, examples of ways that within the bureaucratic organization that you are creating that sense of urgency better than before?
Yeah, I think so, and I'm really proud of the 24,000 mental health providers and their staff. I think the way we show that is by absolute accessibility on a same-day basis. And even in places that are going to just open access to get veterans in, we will see almost 22 million ambulatory visits for mental health. And we're very proud of it. We're continuing to retain and attract behavioral health providers. The increase in our telemedicine work where we'll move from 13% of veterans to this year, about 20% of veterans eligible or able to participate in telemental health is extraordinary. I think all of this demonstrates our commitment. But as I said earlier, simply hiring more mental health providers will make access better, but it won't fundamentally change the problems of homelessness or fundamentally change the problems of financial challenges or relationship changes. You know, in the last 18 years, the Department of Defense has done wonderful work showing the problems with dwell time, that you can't go out for 15 months to combat, especially combat that is intense every single day. You know, you go back to the Vietnam era. One of your colleagues earlier asked. You go back to the Vietnam era, people went out for a week and then they came back to the rear and they decompressed. These wars, you are in combat every single day. In the time I spent in Afghanistan, the medical corps gets every bad thing that happens in a war place. It was a flow of casualties every single day. You cannot underestimate the fact that the human mind and the human body must decompress from that. And when you go out for 15 months and come home for a year and then you go out again, is an operational pace with an all-volunteer force that is unsustainable.
Let me shift gears really quick. Last September, President Trump signed legislation I authored that would require the Secretary to conduct a study of 5 years of data analytics of the Veteran Crisis Line. Can you confirm that that process has begun, or tell us about any progress of that today?
I can't, but Dr. Franklin may be able to.
Yes, absolutely. There was a number of recommendations that came from that related to the Veteran Crisis Line, and we have successfully closed out those recommendations.
Recommendation, this was mandating a study of 5 years using data analytics to study the effectiveness of the Veteran Crisis Line.
Okay, forgive me, I may have crossed your question with the IG recommendations, but absolutely we can check on that and get an answer back to you for the record.
Thank you. My time has expired.
Thank you, Mr. Banks. I appreciated your questions. And Dr. Stone, I've asked my staff to take a look at this response that you gave on the nature of the deployments and how they differ today. Now recognize Mr. Pappas for 5 minutes.
Thank you very much, Mr. Chair, and I appreciate the panel and your thoughts here today as we confront this critical issue for our nation and for all our veterans and their family members. I wanted to build off of one thing that Dr. Stone was discussing, and that was the VA police force. And you indicated a little bit of the training that goes in terms of identifying the signs, and I think that's a really important discussion to have, ensuring that they have that experience under their belt. We should be treating this as any other medical issue. So knowing the signs of mental illness should be just like knowing the signs for stroke or heart attack or anything else that someone might walk into a facility experiencing. But I'm wondering, beyond that, as we look at the IG report around VA policing, if you have any further comments that you'd like to offer in terms of implementation of the recommendations. There was concern around ensuring that police units were appropriately staffed at VA facilities around the country. And if you don't have anything further to add on that right now, certainly we can follow up and have a further discussion following this hearing.
I do. I think there's a number of things that are troubling in the way we've structured police and police management. We are actually going through a process of restructuring regional management. There's very little career mobility in the VA police force. It is pretty much run as a police force out of an individual healthcare facility. Because of that, it's hard for us to retain police officers. In addition, we have graded police officers at too low a pay scale, and our ability to retain very high quality officers is really challenged. So there's a number of areas I'd be happy to take offline with you that I think we could do a much better job of retaining these great officers that we have.
Thank you. I appreciate that. And we'll certainly be following up. As you know, on April 12th, the administration's ban on transgender service members went into effect. I have concern for that group. As you may know, transgender veterans are known to experience suicide at higher rates. And I'm wondering what thoughts have been given to the handoff as these folks leave service in terms of making sure that they're getting the care that they need.
So there has been no change in the VA's posture, and that is that we continue to welcome all service members to care. We provide all care regarding transgender work. The only thing we don't do is the surgery. And but we welcome all transgender members, and we'll continue to do so. And Dr. Franklin?
Sure, and I would just add that so much so with regard to Dr. Stone's comment, we've recently developed a toolkit for all of our medical providers, and it's listed on our website, and we've disseminated it across the entire enterprise. It really speaks to how to engage with this unique population, and exactly what you note, their increased risk for suicide, particularly when you look at the non-veteran suicide data, points to 12 to 19% increased risk with this population, and so we got out of that, in front of that as early as we could, develop the toolkit, and we're training our staff with a series of webinars on it as well.
Thank you very much. I'm glad you handed out these cards and made sure that we all put the number in our phone. This has been an important resource to our district office as we get calls from vets in the state of New Hampshire. And I'm hoping that you'll continue to look for ways to elevate this resource as you implement the VA's national strategy for preventing veteran suicide. As you explained, there are well-followed practices and procedures that are in place when a veteran calls who's in crisis, who's experiencing suicidal thoughts. I wondered if you could comment on other situations that might come up on the line, veterans who may be experiencing depression or mental illness, and how those cases are handled. And I'm wondering, I guess, what resources are available to clinicians on the crisis line, local suicide prevention coordinators to help facilitate services for these individuals, and I'm thinking particularly around transportation.
Absolutely, it's such a good question because not all the calls that come to the Veteran Crisis Line are crisis-related, but all the calls are important, and we tackle them in the same way. So we assess and triage and get folks into care depending on the level of care that they need and what they identify when they call the crisis line. In some cases, that care might be a warm handoff to a vet center. In some cases, it might be a handoff into a community-based organization or one of our own medical centers in a non-crisis capacity. When you're thinking about transportation, transportation can absolutely be a barrier to care. We have a number of entities where we're funding transportation capabilities. We're also partnering with a number of agencies. There's a good example happening in Massachusetts with Mass General, where they're partnering with a local police force for off-duty police officers, and maybe you're familiar with it, part of the home base capability that's connected to Mass General, whereby retired police officers and off-duty police officers are helping to do that transportation piece of it, making sure that that doesn't become a barrier for people getting into care when they need it most.
Thank you very much. I yield back.
Thank you, Ms. Pappas. Now I recognize Mr. Muser for 5 minutes.
Thank you, Mr. Chairman. And thank you, Dr. Rowe. Thank you very much to our witnesses. Appreciate very much your service. Clearly, you're all very, very experienced and capable to be handling these important jobs, and I just really want to thank you for your service. I do represent Pennsylvania's 9th Congressional. We have over 50,000 veterans. We also maintain Fort Indian Town Gap Army training facility, as well as the Lebanon VA. 70% of the 20 suicide deaths per day among our veterans, which is absolutely heart-wrenching, have not received VA health care, as we've been discussing, for the previous 2 years. Conversations that I have with the Lebanon VA have made it clear that we need to work on meeting veterans where they are. And for example, the Lebanon VA has partnered with local colleges, veteran-oriented campus groups. The VA provides instruction for college faculty to identify challenges and have VA staff contact points for veteran students who, on a volunteer basis, who are willing to help. So, Dr. Franklin, I'll ask you, can you speak about the importance of community engagement, the need for such outreach? Is this something that is encouraged and is regularly practiced?
Yes, and I think it's something that's been practiced even more so in the last year and a half, this idea of partnering and outreach with community. And there's a number of different ways that we're doing it. On the one hand, at the national level, certainly putting the right MOAs and MOUs, memorandums of understanding and agreement, into place, and so that we solidify those relationships so that they stand the test of time. And then also informal relationships, and I appreciate the fact that they're doing that right out in Pennsylvania, because we're teaching at the national level for them to do the same thing locally. And what we're doing is we're asking them to use their data, and to use their data to define where to go for partnerships. And so when we look at the data and we see large numbers, our highest rate with 18 to 34-year-olds, we are asking them to work with veterans where they work, live, and thrive. And in some cases, we believe they may be in university settings. So the fact that you note that they're developing partnerships, trying to get after suicide outside the four walls of our VA system, and that they're doing it with community partnerships like universities, tells me that they're on track, and that's the future of the organization. We're really trying to push for broad partnerships, and this focus on the fact, as the chairman said, that we can't do it alone, and we need to increase our partnerships and community engagement.
Thank you. The Lebanon VA also makes its grounds very inviting, its lobby inviting, creates a social atmosphere for the veterans, and in many cases their families. They have a military museum within the facility. Is this something that's encouraged in other VAs? Dr. Stone?
Yes, sir, it is. It is encouraged across the system. Many veterans find this a welcoming place and a place of social connection, and that's the big key to what we're discussing. It's why, for the veteran that wants it, we have chapels on our campuses. We have various veteran-related memorials, and these all seek to connect the veteran back to us and bring them into the system.
Yeah, that's very much in line with what you were referring to a couple of times today, so I'm glad to hear that. Do you consult with the DAV, the VFW, and the American Legion? Many of the members are here today, I think, as well, on these issues. I mean, get their ideas on what they think should be done?
We do. In fact, I've just finished a series of breakfast meetings with as many VSOs would be willing to meet with us. And I think we met with 18 different organizations. The specific question was how to solve this problem. And it is my belief, as you've figured out already from my earlier comments, that belonging, being part of something, has huge value. Therefore, I believe that membership in the VSOs is protective. Now, we can't demonstrate that because nobody keeps numbers on that, or very few of the VSOs do. But we believe it's protective and has huge value in connecting the veteran to the community.
Thank you. And you can clearly see by your words and intonations your dedication, all of you. So thank you. On behalf of veterans, certainly in my district and everywhere, thank you. Chairman, I yield back.
Thank you, Mr. Muser. Ms. Luria, you're recognized for 5 minutes.
Thank you. Dr. Stone, in the Department of Veterans Affairs FY 2019 Annual Performance Plan, Strategic Objective 2.2 states that the VA ensures at-risk and underserved veterans receive what they need to eliminate veteran suicide, and includes 3 recommended interventions and follow-up care. Are you familiar with this objective, and do you know what the percentage metric was for satisfactory performance?
I am not, but Dr. Franklin may be.
Dr. Franklin, are you familiar with this?
I'm not sure I'm familiar with them exactly. I know that you might be talking about our REACH-VET intervention.
Well, it was the only metric within the 2019 Annual Performance Plan for the entire VA that I could find that related to suicide. And in this objective, it stated that you would have recommended interventions, 3 recommended interventions, and follow-up care. And so in the performance plan, it said that you would seek to achieve this 65% of the time. Yet, Dr. Stone, earlier in your remarks, you said that this was your number one priority and that you were putting all efforts behind, being 100% effective in this area. So seemingly the 65% is a relatively low measure of effectiveness for your number one priority. Would you agree?
Congresswoman, I must admit to you, I am not familiar with this, and I would be more than happy to take a look at it and get back to your staff in the next 48 hours to talk about it.
Okay, I appreciate that. I'd like to follow up about that particular metric, since, like I said, it was the only one in the plan that refers to suicide.
Well, because if I might just go on for a minute, many of these, so I came back to VA in July, and this may be a document that was created before I came back, but we will resolve this for the committee, and I apologize to you for not being able to answer the question.
Understand, and I'll look forward to the follow-up. Dr. Franklin, last week I had the pleasure of meeting with a Veterans Outreach Program specialist and several counselors from one of our vet centers in the Hampton Roads area, and they were all incredibly dedicated to their mission and specifically focused on helping to end veterans' suicide. And the Veterans Outreach Program specialist explained, how he gets at this problem of reaching veterans in the community by going through barbershops, faith community, all types of different things where he reaches veterans in places where they are. Do you find this particular role within vet centers to be effective in helping reach those 14 out of 20 veterans that are not receiving care now?
Yes, absolutely. This is a critical role, and I appreciate the fact that you're mentioning barbershops because we're pushing them towards what we call non-traditional partnerships. And certainly our partnerships with VSOs, and we want them locally to reach out to people that connect that we've already mentioned on this panel today. But one of the things I've really been pushing the workforce towards is to reach out to partners who are non-traditional, and
Right, I understand.
barbershop
And in
would fit
interest of
that.
time, I understand the effectiveness of that tactic. I'm just wondering, are we requesting enough funding, and do we have enough personnel in this role within the system to do this effectively across the country?
So we have 300 vet centers, including mobile vet centers, and I think we have enough personnel, but I spoke earlier today with the chairman and discussed the fact that we must begin to move to much smaller engagement units, and I think the vet centers have been that model. But please remember, it took the Vietnam veteran about 10 years to decide that they would come in for therapy. They didn't want to come into our...
I'd like to move on. I only
Yes,
have
ma'am.
1 minute left, and I wanted to touch on one thing, which was your outreach budget. And looking at last year, only $1.5 million of the $6.2 million allocated for paid media, or slightly less than 25%, was spent towards that effort. For FY19, budgeted is $47.5 million in suicide prevention. How much of that do you plan to use for paid media?
So if you break down the actual budget, one of the problems we had that you reference is that prior to 2019 budget, we lumped all of this together, and it was very hard to track. So when I arrived, we broke this out into 6 separate buckets so that we can track it. There is $206 million in those buckets. We expect to spend all of it.
So we're about halfway through the fiscal year. Would you anticipate that we're on track based off of the time remaining in the year to expend all of it effectively this year?
We've expended as of March 30th, just under 50%. We have some additional obligations, especially in our centers of excellence and our demonstration projects, that although we've obligated the money, there was about $8 million that we pushed out to the field. Those obligations haven't come back in, but we do expect to obligate all of that money.
Okay, and very quickly, what measures of effectiveness do you have for that spending? Are you tracking the number of engagements based off of the paid media that you're doing? And do you have any way to report back whether that spending is effective and you're using it in the best methods?
We are, and
applied to next
certainly
year's
I am
budget?
not an expert in advertising or in how they measure this, but as the measures that are beginning to come back indicate that they have been quite effective at recognition. The question is, will they change behavior? And Dr. Franklin may have additional comments.
Okay, and then
Yes.
specifically, like, can you tie that to increased calls to the crisis hotline or any other tangible metrics that you'll be able to report and track over time and provide back to us based off of that spending?
Yes, absolutely, we can. We're doing it through two primary metrics.
Dr. Franklin, I'm going to have to ask you to get that back in writing because move this along. So it's a good question, but could you just
I
respond?
can take it for the record and get back to her, sure, certainly. Yes, sir. Yes, sir.
Thank you.
Yes, Chairman.
Thank you. I'd like now to recognize Mr. Barr for 5 minutes.
Thank you, Mr. Chairman, and thanks to Dr. Rowe as well for holding this very important hearing, and thanks to our witnesses for your dedication and focus on this national crisis. I did want to ask Dr. Stone about the topic that Mr. Bost was asking about in terms of the increase in overall commitment to the VA since 2005, approximately a 258% increase in funding dedicated to VA mental health care, and yet we do continue to see, unfortunately, a rate of suicide at over 20 a day. You mentioned a couple of things that I wanted to kind of explore and kind of unpack what's going on, why we haven't seen a decline in the total numbers. Is that, I mean, and you noted that there were a total number of deaths by suicide among middle-aged and older adult veterans is the highest category. But we do also see from your suicide data report that the rates of suicide are highest among the youngest veterans. So the rates are higher among the youngest veterans, and I did note from the Iraq and Afghanistan Veterans of America testimony that veterans aged 18 to 34, the post-9/11 generation, has the highest rate of suicide. Is that the explanation for why the numbers are still elevated, even though we have made an additional financial commitment to addressing this national crisis? And if not, what is the cause of that?
Maybe some of my colleagues can, but I don't think I have a full answer to that question, except I absolutely believe that not all of this is about mental health. I think significant amounts of this relate to personal, financial, and relationship-based problems and loneliness and isolation. Secondly, you and I both know that the post-9/11 generation of veteran joined the military knowing they were going to combat. That is a unique individual in America that has not only joined but understands they were absolutely going to war. And the effect of that I've already discussed in the effect of recurrent deployments and what it does to ongoing relationships.
Thank you. Recently, my hometown of Lexington, Kentucky, reached an important milestone in ending veteran homelessness. After a multi-year collaborative effort, it was certified that no veteran was living outdoors or unsheltered, meaning that the VA certified an effective, quote, end to veteran homelessness in our community. This milestone is particularly important because, as many of us are aware, homeless veterans are at a significantly higher risk of suicide than non-homeless veterans. Dr. Stone, Dr. Franklin, I noticed that many suicide prevention resources that the VA provides are available only online or by phone, or information about mental health services are sent via mail. Given the higher the higher rate of suicide homeless veterans face, how is the VA reaching homeless veterans who obviously don't have access to those resources?
Yes, we have 444 suicide prevention coordinators with a surge underway to plus that up by a number of 246 more. And they actually do in-person outreach engagements where they are out in communities. We have a metric for them to do at least 5 face-to-face outward engagements to tap into people, just like you mentioned. And many times when I do my checks and I go out and do visits at the VA, they talk with me about these, that they do many more than 5. 5 is the requirement, but they're out, they're tapping into veterans where they are out in these communities, and they're familiar with shelters and local entities where the veterans are, and they're doing face-to-face outreach engagements.
Let me, another quick question about the National Guard. Obviously, certain National Guard members who never federally activated are not eligible for VHA mental health services, yet they may go to the VA for help in a time of crisis. How does the VA handle these Guard members who seek help?
We do not turn them away. We treat them, we bring them into the fold, we give them care immediately, right away, barrier-free, access-free. Furthermore, Dr. Stone signed an MOA this year with the National Guard and the Reserve leadership to have our mobile vet centers out at every drill weekend, and we did a 1-for-1 match with every drill weekend to assign it to a mobile vet center so that they're getting care early and consistently over time.
And in my remaining time, briefly, equine-assisted therapy, We see this in central Kentucky, the horse capital of the world. Dr. Franklin and SAMHSA, any of the witnesses here, what is the evidence in support of these adaptive sports therapies?
So we have a whole center at the NIH that focuses on alternative therapies or non-pharmacological therapies. What we find from most of this work is that they share components that are relevant to treating mental illness or suicide risk. I'm not as familiar with equine-assisted therapy, but it does have key components of things like mindfulness and connection and attachment that are key components of a lot of our evidence-based therapies like cognitive behavioral therapy.
Thank you. My time has expired.
Thank you, Mr. Barr. I now recognize Ms. Lee for 5 minutes.
Thank you, and thank you all for being here and sticking through this. First of all, I appreciate the approach, the whole health approach that you're taking, and I wanted to address what you said, Mr. Stone, that it's not all about mental health. And in the CDC report that was included in our packet, it reported that more than half the people who died by suicide did not have a known mental health condition. It went on to say that many of these deaths were preceded by economic losses, physical health problems, and housing stress. And it further said that, went on to identify 7 strategies for helping deal with those individuals who are identified as high risk. The number 1 strategy was economic support. Given that the highest, we're seeing a biggest increase in our younger veterans, and we're seeing a big increase in suicides across the country in our young members of our society. My question is, have you done any tracking on access to economic benefits, to the veterans' benefits? Has there been any tracking in terms of risk, in terms of who has committed these suicides? Have they had trouble accessing the VA benefits, et cetera?
So we do know anecdotally that there is financial problems related to a number of the recent on-campus suicides. But I cannot create a pattern for you that this relates to what I believe is anecdotal. We do know, however, that at the point of impending homelessness, the incidence of suicide rate, which in veterans is just over 30 per 100,000, dramatically goes up to about 80 per 100,000 population. So financial instability is an absolute risk factor.
So I want to get into tracking and what you're doing also with respect to the Department of Defense and the executive order and the electronic health records as the chair of the subcommittee. I understand that you're collaborating on the screening tool for the new electronic health record system. What is the status of that collaboration?
It's an active collaboration at this time as we try to create a common platform that will allow not only access to data, but common clinical pathways that allows us to capture information in the same way.
Are there specific aspects of DOD policy and practice that you're incorporating and vice versa?
Yes. Yes, there is
Can you
active
elaborate?
collaboration, and the IPO that works with us to collaborate is actively engaged in this, as are the work committees. We have 18 different committees that are working to collaborate.
Well, seeing that the IPO is not fully formed, that's sort of a problem. And the fact that the Department of Defense has not agreed to come to a roundtable that we had to discuss about this, I mean, we're not there. I don't see evidence of the IPO.
So the IPO has been in existence for a fair length of time, and we've been working together for years as we've worked through this. Both secretaries committed to enhancing the IPO, and we are still working our way through those processes. But as I stated earlier, I have found DOD a wonderful partner in this.
So when the electronic health record goes live next spring, will suicide risk be a flag that's immediately available?
Yes.
And are there any flags that will not be available by go live?
I would have to bring the work group leads that are actually working this. I will be attending in Kansas City next month, one of the work groups myself, to actually work through this process and observe it. We have had 4 separate meetings that have brought clinicians and leaders together in order to make these decisions. The 5th will occur in the next couple of weeks, and then I'll be out at work group 6 in order to work our way through this.
Okay, great. One final question. What data will be collected from the Health Telenet platform, and how will it be used for further development of effective interventions?
We'll have to take that for the record in terms of the specific data for telemental health.
Mm-hmm.
Okay.
All right, thanks. I yield.
Yeah, thank you, Ms. Lee. Mr. Cunningham, you're recognized for 5 minutes.
Thank you, Mr. Chair, and thank you to every one of you for attending tonight. Suicide prevention coordinators are critical to VA's efforts to prevent veteran suicides. I wanted to see if you all could speak to, in your opinion, as to what shortcomings the VA has with suicide prevention coordinators as far as mistakes they may make or any issues or weaknesses found within that particular employment.
Sure, I can take that. We have, I said earlier, 444 suicide prevention coordinators around the nation. I would note that we're the only hospital system that has employed full-time suicide prevention coordinators to get after this issue. We are in the process of hiring up another 246. This is based on an analysis that was done over the past year that recognized the fact that we plussed up our veteran crisis centers. As you well know, this has been briefed to this committee. And then we also created a new capability called ReachVet, which is a predictive algorithm that produces a red flag and looks at a number of variables and provides a force function for our SPCs and others inside the hospital system to do caring outreach to veterans that present with high risk. And so that has created an additional workload and burden on this capability that was stood up over 11 years ago. And as well, it is a time to just continue to reset and refresh the community. We offer a training for them every other year in collaboration with DoD called a DoD VA Suicide Prevention Conference, where we do an ongoing assessment of their needs, and we make sure that we're training them with the latest evidence-based practices and that we're supporting them. They are taking care of our nation's veterans who are at most high risk, and we care for them as well, and we want to make sure that we're providing them the best care possible. We recently also conducted an analysis to further advance public health entities other than just suicide prevention coordinators that are doing straight clinical work. We want to make sure we're doing additional work outside the community with outreach so that it's a holistic approach.
Right. And of those 246 additional hires, how many are vacancies waiting to be filled, if any?
So those are not vacancies. Those are additional plus-ups above and beyond.
Are there any current vacancies waiting to be filled?
We don't have the vacancy rate with just SPCs, but we have it with our mental health writ large, which includes all of our social workers and psychologists and others, and the vacancy rate hovers around 10%. I know Dr. Stone might want to add to that.
Yeah, I do. Because we're working with a segment of healthcare delivery that no one else has ever done before, we're still figuring this one out. And when I say that, the average suicide prevention coordinator will have a cohort of about 90 patients. But yet, not all of them are they contacting every day. In some instances, especially in those people coming out of our emergency rooms that are at risk, they are being contacted by the nurses or actually even the provider. We implemented, as was mentioned by my colleagues, a post-suicide attempt suicide prevention contract that I have spoken about previously, not here today, but in previous testimony, that has been pretty dramatic at reducing future suicide rates. But the individuals that are actually interacting with that at-risk veteran are either the nurses or the actual provider that cared for them in the emergency room. So adding the additional personnel is a recognition that we continue to grow in our engagements in our veteran crisis line as well as identifying at-risk veterans by going through what we call our REACH Vet program. We have now identified over 30,000 veterans that we consider at substantial risk of future suicide, and making positive contact with them is essential.
I appreciate that, Dr. Stone. And one final question for you, as I'm trying to ascertain what you testified to here today. Let's say you're king for the day, and for every extra dollar of funding that you received, how much of that would you put into addressing mental health within the VA hospital and suicide prevention coordinators, addressing the issue head on, and then what percentage of that dollar would you allocate towards the issues you previously identified, whether it be homelessness or economic, basically those underlying factors?
I think having sat through the last couple hours here with me, you will understand very well my answer. This is not a financial problem. This is a problem of the society that we live in. And this is about the interpersonal connections that we each have to each other as a society. I can hire another 20,000 mental health providers. And what I can say to you is that people in crisis will get great care, and they will come in or be seen in the same day as they are today. I can hire additional people for at-risk. But this is about moving to the left, moving towards the fact that we need to reduce risk. And it goes back to your colleagues' comments earlier about whole health and identifying what connects us as humans to other humans and finding stabilization as a society that is much different than it was for those veterans that came home 30, 40, and 50 years ago.
Appreciate your time. I appreciate the service each of you all provide. Yield back.
Thank you, Mr. Cunningham. Mr. Cisneros, you're recognized for 5 minutes.
Thank you, Mr. Chairman. I just want to thank all the witnesses for being here this evening. Dr. Stone and Dr. Franklin, I sat down and had a conversation with the director of the VA Long Beach Medical Center, and he mentioned a pilot program that they're running called the Veterans Medical Evaluation Team, or VMET. Have you heard of it? Yeah. So for those of you who don't know, this program, it's a partnership between the Department of Veterans Affairs in Long Beach and also law enforcement, local law enforcement, to proactively reach military veterans in trouble, even if they're not connected with the VA system. They train local police officers, even a VA clinical technician will even often go with the law enforcement officer on calls when it's regarding a veteran. He touted this as a very successful pilot program that they're running. And we heard about several other examples of successful pilot programs that local VA hospitals are running as well, just here this evening. How is the VA kind of collecting this data from these? I mean, you're encouraging the local VA hospitals to go out and to run community programs, but how is the VA overall collecting this data and then deciding if these pilot programs are successful and then trying to implement them out on a larger scale?
It's a very good question, and I appreciate this example that's happening in your area, because we have 24 cities that are working with us and 7 states. We call them Mayors and Governors Challenge, and they're implementing, just as you described, creative evidence-based approaches that involve training community members and accessing care and reaching veterans where they work, live, and thrive. We bring them in collaboration with our colleagues here from SAMHSA to train them on these approaches so that they can execute these, and we monitor them over time through a technical assistance arm that is offered through my colleague Richard McEwen, who's here today, and we do it together. We host a series of monthly calls with local mayors and governors county teams to learn the best practices, and we've created an online IT platform where we call it a community of practice, where they can also input their best practices and the data into this platform where anybody across the VA can go in, look, share, and learn. And so that's a little bit of how we're doing it. I want to have Dr. McEwen also share, because he's helping us on this effort.
Yes, we are. I think it's a very important initiative, because it's really trying to promote comprehensive approaches to suicide prevention at the local level, which is what we think is really needed. And so we look forward to our continued partnership with the Veterans Administration around this work. both in the cities, in the rural areas, and among states.
So we're sharing best practices, which is great, but has there been any example of a program where you've taken a program and said, okay, we need to implement this nationwide because it's working?
Yes, I'll give you one example that was actually done under the leadership of Dr. Stone, and that involves our ER work. So there was an initial early study that spoke to the importance of aftercare when people leave our ERs, where they're getting this simple intervention, also mentioned by my NIMH colleague, around caring outreach with a phone call to veterans when they leave the emergency room. And it pointed towards significant reductions in suicide when they have this caring outreach. And we had done it in a pocket, I believe it was 7 of our facilities, and we had tracked the data over time in a small pilot. And when Dr. Stone got in the seat of the executive director, we had a series of meetings and put it on a fast track for full implementation across the entire VA system, every ER. I don't know if that sounds like.
This is specifically directed at survivors of a suicide attempt. And as was mentioned earlier by our colleagues, they had seen a 30% reduction. We're actually seeing a 50% reduction in future suicide attempts.
Good. Yeah, like you've heard numerous times today, it's going to take a village. The VA can't do it by itself. Everybody's going to need to get involved, working with local law enforcement, local officials as well, to make this all happen. The last thing I have, just you had mentioned the program that you've been working with the Air Force to kind of, you've been able to work with the Air Force to kind of help minimize their numbers. As the first I heard of this program, I would love to see more information about that. And I would really, if it's being so successful with the Air Force, why haven't we been able to implement it with the other services?
I would not speculate, sir, on what the other services have done or not done. I've been out of uniform since 2014. I can tell you that we in VA are incredibly intrigued with the fact that the Air Force has taken as far back as 1996 the integration of suicide prevention strategies and integrated them into virtually every level of officer and enlisted training. And in response to 18 years of warfare, they've seen almost no increase in Air Force veterans or Air Force active service members of suicide rates.
Well, my time has expired, but if you could make that program, the information about it available to us, I'd appreciate that. Thank you. Thank you, Mr. Chairman.
Thank you, Mr. Cisneros. Ms. Underwood, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Dr. Franklin, annual reviews of VA suicide prevention and mental health services have found that most veterans receive good mental health care from the VA. Despite that, though, the suicide rate for veterans in my home state of Illinois is almost double the rate of the general population. I'm a public health nurse, so I prepared for this hearing tonight by reviewing the medical research on the subject, and I'd like to walk through some of that research briefly with you today. Suicide attempts for service members are more likely to result in death than they are for civilians. Is that correct?
Yes, ma'am, it is.
So let's talk about what the research says might contribute to that so we can make sure we're implementing evidence-based policies to prevent it. You're aware that both men and women veterans have much higher rates of firearm ownership and easier access to firearms than the general population. Is that correct?
Yes, Chairman.
Okay, and so veterans, of course, are already more familiar and comfortable with firearms than the general population. Is that correct?
Yes.
Okay, so we know that both men and women veterans are more likely than civilians to use firearms for suicide. Is that correct?
70% more, yes.
Okay, and so this is especially more dangerous because attempting suicide with a firearm is more deadly than with any other method.
Absolutely.
Okay, so I really do commend the VA for calling attention to firearm suicide among veterans. And currently, the VA's National Suicide Data Report found that interventions focused on preventing self-harm by firearm are integral to preventing veteran suicide. Since 2008, the VA has offered free gun locks to veterans in an effort to reduce suicide. Is that correct?
Yes, we have.
Okay, and so the VA has an educational campaign as well. I saw flyers myself during my visit to the Level Healthcare Center back home last week, but obviously veteran suicide remains at a critical level. VA health professionals receive training on providing lethal means counseling to veterans. Is that correct?
Yes, we do.
Okay, can you tell us what that training looks like?
The training is focused on how to talk with veterans in a firearm-friendly way that's culturally relevant. What we don't want our clinicians to lose veterans or to turn them off by using the wrong term or to have them begin to talk about this issue in a way that brings it into the public square and is a potential political issue. We teach our clinicians that it's about safety, and the training is focused on protecting the environment, as is the last question in the safety plan that both of my colleagues here from SAMHSA and NIMH mentioned. It's about assessing the environment for all causes and manner of safety issues, and we focus the training on putting time and space between the person at risk and the identified means, with many of the things that were talked about at this hearing this evening, like whether it's the freeze method or storage of firearms, or even having a peer involved and having a peer hold a weapon while a veteran is at imminent risk. Yes.
And so who receives the training? So, you mentioned that the professionals do get it, but which category is a professional?
Mental health professionals.
Okay. In the written testimony, it talked a lot about how many veterans receive primary care, and most or many of these screenings are done by the primary care providers. Do you see any utility in training your VA primary care providers in these methods?
Yes, if it were up to me, we'd train the entire VA on how to talk about lethal means. It's a short training, it's available online, it's easy to take, and we would monitor and assess it over time and continue to make it better. Absolutely, yes, ma'am.
Is that a resource constraint that prevents the primary care providers and others being mandated or required to undergo this training?
Quite honestly, I don't think it's about resources. I think it's about getting their commitment and getting them on board to do it. We certainly have work to do in this space to make sure the primary care docs prioritize that in their training rotation and platform, if you will.
Okay, well, I think that this committee would certainly support elevating that among the priority measures for the primary care providers, and if there's anything that we can do to accelerate that, I think it would be useful. We want to make sure that all healthcare professionals are armed with the resources that they need in order to properly service our veterans. Has the VA engaged at all with firearm dealers and ownership groups to find ways to increase their involvement with veteran suicide prevention?
Yes, absolutely. That's why we have a partnership with the National Shooting and Sports Rifle Foundation, which I mentioned earlier. It's an MOA, so it's an official partnership. It involves up the whole leadership chain. It's not just with my single program. It's between the whole VA and the whole National Shooting and Sports Foundation. And it also involves the American Foundation for Suicide Prevention, which is another nonprofit that's heavily engaged in the research in this space. And it calls for the three agencies to work together to bring firearms owners, dealers, and even trade organizations to the table and teach them about signs and symptoms of risk. Actually, the state of New Hampshire has had quite a bit of success in this, and as has the state of Colorado, and so we're doing quite a bit of work in this space.
And when you say bring together, are you actually hosting these convenings?
We're not hosting them at the national level, but they sure are hosting them locally. And they're even going door to door to firearm dealers and people that sell, and they're talking with them about suicide risk. Richard McEwen may have some additional information.
So in numerous states, this kind of work is going on with SAMHSA funding. So SAMHSA is not convening those meetings directly, but our funding that goes to states has been used in a number of different states to fund this kind of activity.
Well, thank you so much for sharing this information. I do think that there might be some utility as we explore evaluating these types of partnerships and seeing if there's more of a direct role that these agencies can play, and certainly if our committee can be helpful in accelerating that, we stand by to do so. Thank you.
Thank you, Chairwoman.
Mr. Rose, you're recognized for 5 minutes.
Thank you, Mr. Chairman, and to the witnesses, thank you so much for being here today. Dr. Stone, Dr. Franklin, I can see that you're deeply committed to this issue. My fear is that there are some things, as you've mentioned, that are out of our control. And I'm saying this as someone that was an infantry platoon leader in Afghanistan 6 years ago. And one thing is our operational tempo and the intensity of our deployments. So my questions today center around the effects of these issues on suicides. I'm going to read off a few statistics to you, and then I have a few questions. In a report published in 2018 by the Uniformed Services University, it's shown that those who served 12 or fewer months before their first deployment were approximately twice as likely to attempt suicide during or after their second deployment. Also, in additional studies, those redeployed within 6 months or less were 60% more likely to attempt suicide. Were you aware of these statistics?
I am.
Have you seen any further causal relationship between the number of deployments and the intensity of deployments as it relates to suicide, between the 18 to 34 demographic, particularly the post-9/11 combat veterans?
Certainly, there are some deeply troubling issues regarding operational pace that you bring up, and I referenced earlier in testimony, and that is not only the intensity of ongoing combat in a 12 to 15-month deployment, as well as the dwell time when we bring service members back. That was extensively studied in the Army STARS program. It was also a point of interest for General Chiarelli as the Vice Chief of Staff of the Army, who spearheaded a number of studies on dwell time and relationship-based effects related to the amount of suicides in ground troops in both the Army and the Marine Corps. And all of that work was done in cooperation with the Marine Corps.
So my question, though, is as you see further evidence relating deployments and op-tempo to suicides amongst young men and women, do you think it is within your purview to make recommendations to the active duty Army as to what they should change? And note that if they do not change those things, they are creating an avoidable and what I would argue incredibly wrong risk of suicide amongst our veteran populations. Do you think that's within your purview to make those recommendations to the active duty Army?
I think that identifying data and sharing that data with our uniformed colleagues is entirely appropriate.
And so,
I am not the decision maker.
No, of course not, but I'm talking about recommendations. And so would you recommend to the active duty Army, would you say that it is responsible to redeploy soldiers with less than 6 months?
Those are
of dwell time?
decisions that the active component must make.
I'm asking as a healthcare professional if you would say it's responsible.
And I'm saying to you, Congressman, that those are decisions that the active component must make. We can provide data. We can share that data. We have a cooperative environment in which we as healthcare professionals are discussing this, but you can go back through the 20 years of this war and really look at the push and pull between the size of the ground force and the relationship between the medical professionals that were advising senior leaders, and decide for yourself how that's been handled. I was in uniform for 23 years. I served on the Army staff. I had my chance to say what I needed to say and was welcomed by senior leaders and was proud to work alongside the ground combat forces. That said, my job at this point is to take care of 20 million veterans that want to see us and to take care of their problems. The decisions on dwell time, combat time, are certainly in a discussion between you and those active leaders.
Okay, I understand. Now, moving on to National Guard soldiers, and I'm presently serving in the National Guard. How do you explain, what is your understanding of this crisis with suicides amongst National Guard soldiers who have not deployed, and do you think that the training op-tempo has any connection to this? And the fact that it's increased dramatically in the last 20 years?
I think there's some deeply troubling parts of the National Guard, and I referenced this earlier in testimony when I said that every one of these service members joined knowing that they were probably going to combat. This is a different National Guard than simply a Guard that takes care of the national, the state-related problems of floods, hurricanes, and tornadoes. This combat force is an area of debate that has been highlighted recently in a book called Signature Wounds of is the pace too much for the ground combat forces of the Guard. These are individuals that have served tremendously well in combat, but the force, the stress on that force is significant and one that I think we all need to consider.
And do you think it's within your purview to make recommendations to the National Guard?
And we've entered into an MOU with the National Guard, and the National Guard has been a wonderful partner. General Cadavy has been great in our meetings about discussing and trying to do everything he possibly can to reconnect. One of the things that we see is that there is a lower rate of suicide in Guard members than there is in reserve members, in spite of the fact that the Guard is much larger. There is something protective about the connection within states. Remember that the Army Reserve is a force that you might travel 400, 500, or 600 miles in order to do your reserve service. The Guard has something protective about it that we need to study more, and I can tell you that the leadership of the Guard and the Army Reserve has been great about entering in these conversations openly and with a sense of self-examination.
Thank you very much again for your time and for your service.
Thank you, Mr. Rose, for your questions. Mr. Levin. Oh, actually, not Mr. Levin. I'm sorry, Mr. Levin. Mr. Watkins, you are recognized for 5 minutes.
Thank you, Mr. Chairman. Thank you to the panel for being here. These questions will go to anybody who'd like to answer. So, having served lived and worked both in service and as a paramilitary contractor for 8 years in Iraq and Afghanistan, I know firsthand some of the challenges service members face when they come back home. And my question is, how do you, the metric of 22 suicides a day, I want to take a closer look at that for a bit deeper understanding. Is that metric kind of hints and suggests this narrative that it's Gulf War veterans, but am I learning right that it's a lot of those suicides are Vietnam era veterans?
21% of the national veteran suicide number is over age 75. 37% is between age 55 and 74. 27% is between age 35 and 54, and 15% is 18 to 34.
All right, thanks. Is the VA open to, I don't want to, alternative is a very loaded phrase, but other means of therapy aside from psychotherapy, for example, transcendental meditation?
I think you might be talking about complementary care, and absolutely, it's part of our whole health model, and there are a number of treatments. I don't know that the ones that you specifically mentioned are on that list. I can get back to you on that, but we are open to any and all forms of complementary or adjunct care to treatment plans, yes.
And how, do you have data that could measure the efficacy of those as compared to the more traditional psychotherapy?
We don't have data specifically when those are implemented alone. What happens is they're traditionally implemented as part of a broader care system. So for example, a client might get cognitive behavioral therapy with additional complementary care in thus and such, and it's typically evaluated as part of the full system of care, a full treatment plan, if you will, for a veteran.
Are the veterans open to those approaches?
It appears as though they are. I've read quite a bit in the literature about them being open to things like yoga and other forms of that type of therapy.
Are active Guard and Reserve commanders open to those approaches as well? I know it's tough for you to say.
I think there's been tremendous progress in the openness of active leaders to these because they can keep soldiers in the fight, and soldiers do very well with these types of training. I think the early intervention and the embedding of both behavioral health providers with the active component formations has shown tremendous value in both special operations as well as traditional ground forces.
Should those take a bigger role in soldiers' basic trainings?
I think that making service members aware of the role of complementary medicine is tremendously valuable. Probably the hardest data we have really relates to organized sports activities and the protective effect of organized sports activities, and the fact that I think in our last year's report, it identified that about 150 minutes of organized exercise had really demonstrable protective effect in veterans.
Great. Thank you so much. I have no doubt there would be many more suicides if it weren't for your efforts, so thank you for your service. I yield my time.
Thank you, Mr. Watkins. And now, Mr. Levin, you are recognized for 5 minutes.
Well, thank you, Mr. Chairman, for holding this hearing on what is a critically important issue to all of us around the country. particularly in my district in San Diego and Orange counties, very large veteran population, home to Marine Corps Base Camp Pendleton. Had an opportunity during the district work period to visit with the leader of the San Diego VA, as well as have several meetings with many of the veteran service organizations and other nonprofits that are leading in this and related issues. Wanted to ask another question about the intersection of guns and suicide as it pertains to veterans. In its National Suicide Data Report, the Department of Veterans Affairs calls for, and I quote, a continued focus on innovative crisis intervention services. One crisis intervention tool that 15 states have now adopted and that is shown to reduce suicides is called an extreme risk law. When someone is showing warning signs of being in crisis and a risk to themselves or others, these laws allow their family members or law enforcement to ask a judge to temporarily restrict their access to firearms. When Connecticut stepped up enforcement of its extreme risk law, it saw a 14% reduction in the state's firearm suicide rate. And in the 10 years after its extreme risk law went into effect, Indiana saw a 7.5% reduction in its firearm suicide rate. The impact of an intervention tool like this could be magnified for the veteran population because not only do veterans have a higher rate of suicide than the general public, but they are more likely to use a firearm compared to both the general public and to any other method. To each of our panelists, do you think Congress passing extreme risk legislation is one thing we could do right now to help address the veteran suicide crisis?
Well, Congressman, I think that we are very aware of the extreme risk protective orders, and the data from places like Connecticut and Indiana are very encouraging. I was at a presentation just last week around this very issue. In states that have passed this, I think we want to work closely to make sure that family members and others are aware of the availability of this. I'm not really able to take a stance on whether national legislation, but I think that in those states that have taken this, then we want to make sure that those who surround veterans and others who are at risk for suicide are aware of it as a potential.
Thank you, Doctor. Anyone else care to comment? Well, another area that I wanted to address is collaboration between the Department of Defense and the Veterans Affairs Administration. For me and for those that I've spoken with, it appears to be a critical aspect for effective veteran suicide prevention, the relationship between the Department of Defense and the VA. And this means ensuring a warm handoff as service members leave the military, but also sharing relevant information that can inform VA's intervention strategies. I understand that the military keeps track of which service members are at higher risk for suicide. Dr. Stone, my question for you is, does the DoD share this information with the VA? And if not, have you requested or will you request they do so?
I think sharing of the medical records is a lot different than a commander calling another commander when you move a service member or a PCS, a service member. One of the things we implemented when I was still in uniform was warm handoffs between line commanders, not just the mental health professionals. I think we've had an excellent discussion, and earlier we discussed about our combined use of clinical practice guidelines of how we do transitions and handoffs. I think you've identified an area that we could do better, but I will tell you there is good discussion going on, and I am absolutely optimistic that as we implement the electronic medical record on a common platform, the ability to instantly see what's gone on from the time the service member joined the military will go a long way from the longitudinal viewer that we have today, where we have to toggle in and out of our current VISTA system to a electronic record viewer from DoD. So a common platform is essential.
Thank you. Really appreciate all of your work on behalf of veterans, and thank you for taking the time with us tonight. I yield back the balance of my time.
Thank you, Mr. Levin. I want to thank all of the witnesses for appearing before this committee today. It certainly has been a long and strenuous evening, and I appreciate your willingness to work with this committee in combating this tragic crisis. We will be This is a first of, I think, many hearings that we will be conducting, as well as roundtables, and on this topic of veteran suicide. And we will, as I said in my opening remarks, continue to hear from all stakeholders, including the families of those veterans that have committed suicide, those veterans that have survived suicide, and the many other professionals and stakeholders, the VSOs, that have insights to help this committee take action and to really make a difference in reversing this trend that we see in veteran suicide. I understand that the minority does not wish to make a closing statement. I will conclude with these words. To the veterans who are watching this hearing, and to those struggling with the thoughts of suicide, a grateful nation cares for you. Both your service and life are valued, and your continued existence is necessary to advancing the causes for which you so selflessly served. You sacrificed everything to preserve our freedoms. We, as a nation, are committed to preserving your life. If you or someone you know is contemplating suicide or in need of additional assistance, please call the Suicide Prevention Lifeline at 1-800-273-8255. That number again is 1-800-273-8255. And when you call that number, press 1 to get in touch with a professional that is waiting to assist you. All members will have 5 legislative days to revise and extend their remarks and include extraneous material. Again, thanks for all of the witnesses for appearing today before this committee, and this hearing is now adjourned. Thank you, Walter, for your, thank you. Thank you, Republican staff. Thank you very much.